So let's, I know it's lunchtime, almost. So let's first put the slides up. What I want to give you is an update on our patient from yesterday. You remember that he had this huge saccular 6.5 centimeter aneurysm, and there was a big discussion. Go to the next one. Big discussion about what we should do, whether we should do laser fen or a PMEG. And since the imaging system at the hospital sort of broke down and I had to take him to the cath lab, I did it later in the evening. And go to the next one. And we know this. There was this huge accessory renal. It's probably there. And the discussion was whether we should save it, coil it, and it's measured almost 5 millimeters. Go to the next one. And so this is the other thing. They wouldn't allow me or anyone to show live. Next one. Live. These are all the measurements we had taken. Go to the next one. The angles. And so we did what was known as a laser fan. I think Frank made a very, very good point. Sometimes he does, So we put a stent in. So when you do laser fans, and so we put a regular VisiPro stent in, so you could see the angle exactly where that. Then we use the Terumo graft, because like you said, Cook is probably the worst. It has too much of metal. They're too close to each other to burn the hole and everything. So I think Terumo is a good one. Endurant is not too bad, but you have to take into account the length of the body. So Endurant was only 5, and this was very close to 3.5, 4 centimeters. And so we used the Terumo trio graft. Go to the next one. And we were able to fenestrate, and we were able to get a really good result. We preserved both renals at the top and the fenestrated one at the bottom, and we've got a really good result with this one. So the reason I was going to do this live case, go to the next one, is another challenging case. This is an 82-year-old. I don't know whether Dr. Kalpi is in the audience, but 3 years ago, she came in with an ascending aneurysm and an intramural hematoma all the way down. And then I think Dr. Kalpi did an ascending repair, and he debranched the arch vessels, the innominate left carotid. And then the patient did well. We just treated her conservatively till aneurysm was only like 4 centimeters or so. And then she came back with chest pain and shortness of breath, and then this was her CAT scan. And she has this huge, almost like a pseudoaneurysm, just distal to the subclavian. Go to the next picture. There you can see it in both views. This is the axial cut. Go to the next one. So this is the issue right now. As you can see, there's that ascending graft, and you can see the carotid and innominate have been debranched. And so we have a good landing zone into that graft. She does have a huge left subclavian. Go to the next one. And so this is the whole meat of the cases. We sent these pictures for the single branch gore thoracic stent graft. And basically they said that it qualifies, it's a good case. But my concern was the takeoff of the angle of the left subclavian. Frank, you've done a fair amount of these single branch grafts, even live. And so what do you think about the single branch graft for this? Right now we have access in both groins. We've got access in the brachial. We've snared the wire. We've got a brachiofemoral wire. We're going to put our 20-24 French sheath in, and then may not have time to do the entire case, but at least I will show it to you while you're having lunch. You will keep working. So Frank, what's your opinion? Go back to the CAT scan, please.
I think it's a pretty good case. I mean, you got a pretty good landing zone. It's a type 3 arch, which makes it always a little bit more challenging to get the device down. I can't tell by the curvature distally. This might be one where I use a little bit longer sheath, so a 65 centimeter sheath over a 35, just to help me sort of. Sometimes when you're trying to push down that arch, it'll get bent over to the right, especially in that large aneurysm. And then I might also maybe deploy, this is just an aneurysm, right? Not a dissection?
No dissection. It was like an intramural hematoma with a small area distal to subclavian that just ballooned up. 6 centimeters almost now.
That's probably the two things that I would do, but I think it's an overall good case. Jim?
Yeah, I share your concern about the angle, but I think you've got enough room, especially if you bring your port a little bit more forward than you normally do, that will go up and make the turn. So I think you'll be fine there.
Plus you have an access
I debated this with
you have access.
I have access from the brachial, yes.
Yeah, you have access from the brachial.
We have a brachial access.
And then,
I've got a sheath all the way down.
And then the good thing is that you don't really worried about retrograde dissection because you have already an ascending graft there that was placed before. So in a way, you're set. I mean, quote-unquote safe.
I mean, the other option you could do here, Vinky, is, again, while I try to tell people that if you've got something that's FDA approved, I try to use that as a single branch, but you've got a lot of space between that left carotid, that left subclavian and it looks like the left carotid and the innominate. So this would be a case where you could potentially, if you're worried about that angle, just go up, deploy your standard stent graft, and do a carotid subclavian bypass.
Subclavian or laser,
or just do an inside
this
two
was what
laser
we debated.
fenestration.
Yeah, so this is what we even debated was to why not just do a carotid subclavian and then you just slam a graft in, literally. And so then they said, no, it's a good case for the TVA for the single branch device. And so we're going to go ahead and do it. You guys go for lunch. It's already 12:15. And then I'll see you. We'll keep working. And as soon as we're done, we'll present it. So thank you for a great session. I think this was a great discussion. Dr. Caselli, Frank, Jim, Orania, all of you. Thank you so much. Go ahead, have lunch, and I will keep working.
Yeah. So I showed you a case. The fundamental principles of doing live cases is you always show the last picture. Because people assume, as Dr. Frank Arco would saying, that this patient died. If I don't show you the final completion angiograms. So this was a very challenging case, Frank, because of the type 3 arch and getting into the subclavian and then trying to put the subclavian stent through this angulation. We did struggle a little bit, but I think we really got a good result. So we deployed a 40 device, actually. The proximal one was a 37 device with the single branch in the subclavian. Go to the next image. So this is how it all went off. You got to be very careful that there's no twist to this subclavian wire and the main wire going down. And so it was challenging to actually get it down even into the ascending, graft. So we had to push, pull, tug, rotate, all the necessary things that we normally do. And then we were able to get the graft down, and then we deployed the first portion. Go to the next one. Next one. And you have to be very careful where that port is. You don't want it to go too far in or too far back because of that angle, it becomes extremely difficult to maintain a patency and maintain the branch from not twisting completely. Let's go to the next one. And so this is after we put the first piece. And you can see the angles were so bad because of the type 3 arch, we literally had to go lateral almost, and we still could not splay open, the arch of the aorta completely. So we put the first piece in. I was able to push my sheath from the brachial all the way down to assist me. I had to even balloon the port and the subclavian orifice into the subclavian to be able to get that branch graft into the subclavian. And then, of course, this itself showed that we had already sealed that big, huge aneurysm in the distal portion of the subclavian area. But you see the graft is floating in the middle at the distal end, and so we had to put in an extension. Go ahead. Next one. And there you can see that. And so I opted to land just above that little bend over there. I know you don't want to cover too much. We already taken care of the aneurysm at the top, so we decided not to come beyond that bend, and therefore we deployed the next piece, which is the 40-150. Go. And then we deployed it all the way down, and then go to the next one. And that's the final angiogram. And you can see the graft actually landed into the previous graft open surgery that was done on the ascending. You can see the takeoff of the innominate and the carotid branch is well distal to my landing of the graft. The subclavian branch, initially I thought I'd put another VBX balloon expandable stent, to straighten it. But then I thought I would literally kink it because of, the angle of it all. And it looked really good. We shot from the subclavian and we shot from distal with the pigtail, and it looked really good. Go to the next one. So I then took another right angle the other way too, and you can see that there's a complete seal. The subclavian fills up very nicely. The only thing that took me time was that closure device, 2 prolades failed. And then I had to make a small cut down and put 2 stitches in, and that's why I got delayed a little bit. But the patient's doing well. She's moving her extremities. She's in the ICU, and she's doing well. So that's the end of that live case, and I think it was a challenging one, but otherwise a very good result.